Very good afternoon to respected chairpersons, the distinguished audience, and thank you to the organizers for having me here today. So, when we have these very challenging cases, I do feel that I am one of those 6 blind men who are trying to decipher what the elephant is. So, my first case was a term male baby weighing only 2.8 kilos and presented with shortness of breath 3 days for 3 days with little bit of bluish discoloration of the lips. The saturation was on the lower side, 87% in all the 4 limbs, and there was an ejection systolic murmur of about grade 3 in the upper left sternal edge. The SATs were not improving with 100% oxygen. There was acidosis, and the child required CPAP support. The ECG showed a right axis deviation and prominent RV forces, which is usual in newborns. But the X-ray didn't show much cardiomegaly, but there was these increased pulmonary vascular markings. This was the echo. As we see here, it was a case of very, very unbalanced atrioventricular septal defect with a very small LV, prominent RA and RV. Actually, it was almost like a single atrium with a large ostium primum, ASD and ASD. And there was also DORV, double outlet right ventricle, with the arteries being parallel to each other, and there was some degree of pulmonary stenosis as well. So it was when we went for the sequential segmental analysis, it was situs ambiguous with both the aorta and the IVC on the right side. And when we took the subcostal views, but along with the IVC and the aorta, we could see there was this big channel, kind of a big channel which was coming down and meeting the hepatic veins. In the another subcostal view in the lower right side, we can see, in the another subcostal view on the lower right side, we can see another huge channel which is formed by the pulmonary veins meeting just behind the atria, and it is coming down into the liver sinusoid. So this was a case of infracardiac TAPVC as well. So we can see both the right atrial appendages and the venous channel that is formed by the confluence of the pulmonary veins behind the left side of the atrium, and this is the infracardiac TAPVC as well. So this is a pulmonary stenosis which had a gradient of about 45, and the pulmonary annulus was also narrowish. Both the great arteries coming out from the RV, so DORV. And the branch pulmonary arteries were of reasonable size. And we have the en-face view taken subcostally showing the atrioventricular septal defect and the single atrioventricular septal valve and a very, very small mural leaflet. And that is why the LV portion was very, very small. So it was a dominant RV, AVSD. So this is a very, very complicated diagnosis echo-wise, and the complete diagnosis over here. And the child had a very stormy period initially requiring furosemide infusion, and then we also added sildenafil in the first 2 to 3 days, required inotropic support with NORAD to maintain the blood pressure. USG showed asplenia and midline liver as well. Subsequently, at the end of the week, the child was stabilized with positive support and a bit of oral diuretics.